Welcome to the Deep Dive. We're here to break down essential knowledge into something you can really use. And today, well, it's a pretty intense topic, disaster preparedness. What happens when chaos hits and the resources just aren't there? We're focusing entirely on the key frameworks, the priorities, and the nursing management strategies from the source material for mass casualty events.
Yeah, it's maybe one of the biggest challenges in healthcare, isn't it? That moment when capacity is just completely overwhelmed. Our goal today is to give you that blueprint, really, for navigating the chaos, focusing on the structures, the decisions needed when, the usual rules have to change.
Okay, so the first thing we absolutely need to get clear on is the difference between, say, a multi-casualty event and an actual disaster.
Right, and that difference, it really just boils down to resources. Do you have enough? A multi-casualty event,
hmm
that's tough. But a hospital can usually handle it with its own local staff and supplies. Think maybe a bad highway pileup.
Okay, manageable, even if difficult.
Exactly. But a mass casualty event, or what the source just calls a disaster, that's different. It swamps the local medical system. You need help from outside. External resources, collaboration. The second you're out of beds or staff or key supplies, that's the line you've crossed.
So if it all hinges on resources, what are the core principles guiding every decision when you're in that disaster mode?
There are three big ones: safety, teamwork, and collaboration, and communication. Think of them like the legs of a stool holding everything up. Every single decision, evacuating, triaging it, has to anchor back to those three.
Got it. Safety, teamwork, communication. Okay, let's unpack where these disasters come from. They're categorized as internal or external, right?
All right. An internal disaster starts right inside the hospital.
Like a fire.
Exactly. Fire, maybe an explosion, losing power or water, or even, unfortunately, an active shooter.
Yeah.
The main goal there is immediate safety. Get patients, staff, visitors out of harm's way, relocate them, secure your own building first.
Whereas an external disaster means activating the hospital plan because the threat is outside.
Right. Natural events like hurricanes, earthquakes,
Yeah.
we've certainly seen those, or even pandemics like COVID-19. And then there are technologic disasters, building collapses, chemical spills, terrorism, things like the Pulse nightclub shooting, Hurricane Michael. Those are stark examples.
You mentioned terrorism. The source notes that 9/11 really shifted how facilities prepare, didn't it?
Oh, absolutely. It caused a fundamental shift towards focusing on WMD's weapons of mass destruction, specifically those MBC threats: nuclear, biologic, and chemical.
That sounds incredibly complex to prepare for. What did that mean practically for hospitals?
It meant serious investment in readiness, upgrading facilities, especially for decontamination, getting specialized gear, and critically, AZMAT training became essential, especially for ED staff. It wasn't just about some specific attack, it was about being better prepared for any large influx of potentially contaminated casualties.
And this isn't just hospitals deciding to do this on their own, is it? There are standards they have to meet.
Definitely. FEMA provides the big picture framework: mitigation planning beforehand, preparedness active training, stockpiling, response for the actual rescue and care, and recovery, getting back to normal. And the Joint Commission. They require hospitals to test their emergency plans at least twice a year. One of those tests has to involve community partners to make sure everyone can work together.
Okay, so disaster hits. You can't have chaos in leadership. There needs to be a clear structure. That's where the Hospital Incident Command System, HICS, comes in.
Precisely. HICS is that organizational model, puts everything under one hospital incident commander. This person has the overall view, makes the big calls, like moving stable patients out of ICU beds to make space, maybe to a lounge area temporarily.
And who are the other key players under the incident commander?
Well, you've got the medical command physician. They figure out how sick everyone is, how many victims there are, what resources are needed right now. They're the ones calling in surgeons, specialists, getting the right teams activated. Then there's the triage officer, we'll talk more about them in a second, and the public information officer, who handles the media and external communications so clinicians can focus. All coordinated from a central spot, the Emergency Operations Center, or EOC.
Right, that structure is vital, but the immediate action on the ground starts with triage. Let's shift to that mass casualty triage. This is where things really change ethically, isn't it?
It's probably the toughest mental shift for clinicians.
Yeah.
Normal day, you prioritize the absolute sickest person who you think you can save. Disaster triage. The rule changes. It's about doing the greatest good for the greatest number of people.
Which means sometimes you can't help everyone who might have been savable otherwise.
Exactly. Resources are limited. You have to focus on those with a good chance of survival who need relatively limited help quickly. It's a harsh reality driven by scarcity.
Let's break down the disaster triage tag system. Those colors are crucial. What do they mean?
Okay, first up, red tag, class 1, emergent. These people have immediate life threats. Airway blocked, severe bleeding, shock. They need help now, and quick help likely saves them.
So they're the top priority for immediate care.
Correct. Then, yellow tag, class 2, urgent. They have major injuries, yes, maybe an open fracture, but they still have a pulse in that limb, or large wounds, but they're stable enough to wait a bit. Treatment is needed soon, say within 30 minutes to maybe 2 hours, but not immediately life-threatening.
Okay, they can wait while reds are stabilized, then green.
Green tag, class 3, non-urgent. These are the walking wounded. Minor stuff, closed fractures, sprains, cuts, scrapes. They can definitely wait longer, maybe over 2 hours.
And finally, the most difficult one, black tag, class 4, expectant.
This is the one nobody wants to assign, but with limited resources. You have to. These patients have injuries so severe, massive head trauma, extensive burns covering most of their body, that their chances of survival are, unfortunately, very low, even with significant resources. Giving them that care would pull away staff, blood, operating rooms from maybe several red or yellow tags who could be saved. It's a stark utilitarian choice.
You know, something that really jumps out is the risk with those green tags, the walking wounded. Why are they a specific safety concern?
Yes. If the disaster involves chemical, biological, or nuclear agents, those NBC threats we talked about, people who seem okay, the green tags, might walk or drive themselves to the hospital. But they could be contaminated without knowing it, and then they walk right into the ED.
Contaminating the hospital itself.
Exactly. Which is why having a clear, pre-planned decontamination process, especially for self-arrivals, is absolutely vital for safety. And we also have to remember to build plans that specifically address vulnerable groups. Kids, older adults, people with disabilities, folks needing home medical devices. They need special consideration in the chaos.
Okay, let's talk about the nurses making all this happen. They're obviously central. Beyond specific HICS roles, what are the big nursing management actions for expanding capacity fast?
Yeah, boosting capacity immediately is key. 2 main ways. First, getting more staff in. Activating telephone trees, maybe automated alert systems to call in everyone who's off duty. Second, you need to make beds available. That means quickly discharging or transferring patients already in the hospital who are medically stable.
What counts as medically stable in that situation? Who gets moved?
Generally, they look at patients who were admitted just for observation, maybe some diagnostic tests, or patients who've been stable, no major changes, for maybe the last 3 days. These are folks who can likely be safely managed at home or transferred to a lower level of care, freeing up that critical acute care bed.
And it's not just about numbers, it's about roles, too. Nurses have to be ready to step outside their usual jobs.
Absolutely. Flexibility is non-negotiable. Nursing admin might need to move people around drastically. You could have a critical care nurse suddenly working in the ED, or maybe an administrator with clinical skills stepping back onto the floor. The expectation is you perform at your highest skill level, whatever is needed to maximize survival for the most people.
Speaking of safety, you mentioned internal disasters like fire. Can you quickly run through the essential steps for a nurse responding to a fire, the priorities?
Sure, it's all about patient and staff safety first. Think ACE, though the source emphasizes the actions. Remove anyone in immediate danger, patient, staff, visitor. Then, if it's safe for the patient, discontinue oxygen. If they're on life support, maintain it manually. Get ambulatory patients moving. Move bedridden patients however you can bed, stretcher, even a blanket drag. But this is critical. Do not risk injury to yourself or other staff trying to be a hero. Finally, contain the fire. Close doors, windows. Use an extinguisher if trained and safe. Safety first, always.
Going back to the disaster response, you mentioned tracking systems. Why are those automated systems like infrared or radio frequency tags so important for staff safety?
That's about protecting the staff after the event, too. It's for potential prophylaxis. These systems track where each patient went, their condition, who treated them. So if later on you find out patient X had, say, a highly contagious disease or was exposed to something nasty, you can quickly trace exactly which staff members had contact and need evaluation, decontamination, or maybe preventative treatment themselves. It's a huge safety net.
That really brings us to the personal side of this and the recovery phase. It's not just the hospital system that's strained, it's the individual nurse. There's a real ethical bind here.
It's a huge conflict, absolutely. The ANA Code of Ethics guides professional duty, but nurses have families, right? Kids to care for, maybe elderly parents, pets even. The job demands you show up during a disaster. So the source really stresses, Every single nurse needs a personal emergency plan figured out ahead of time. Who takes the kids? Who checks on mom?
And part of that personal plan is having your own supplies ready. The go bag, what absolutely needs to be in that kit for, say, 3 days.
The basics are crucial. Water about a gallon per person per day, non-perishable food, copies of ID, emergency contacts, any personal medications you need, a battery-powered or hand crank radio, and definitely a flashlight or headlamp. The headlamp's better, honestly. It keeps your hands free. Having this stuff ready means you can deploy quickly without worrying about your own basic needs right away.
Okay, so the immediate response winds down, the event is over, but the recovery work is just beginning, especially for the staff who went through it. How do hospitals support them?
Debriefing is essential. It's not optional. Using things like critical incident stress debriefing, or CISD. Specialized teams come in to help staff process the trauma, the difficult decisions, everything they saw. The goal is to prevent acute stress disorder, or PTSD, down the line. Encouraging coping strategies is key too. Counseling, watching for stress signs, making sure people take breaks, limiting shifts ideally to no more than 12 hours, and just creating space to talk about it.
And institutionally, the hospital needs to learn from it too, right? There's a review process.
Yes, they call it the hot wash. It's an administrative review that happens pretty soon after the emergency plan is deactivated. Key people from all the involved areas get together. What worked, what didn't, where were the bottlenecks, what needs changing in the plan for next time. It's about continuous improvement.
And lastly, nurses are often the first point of contact for the survivors themselves, dealing with the immediate psychological aftermath. What's the role there?
It's about being that calm, grounding presence, using active listening. Survivors feel incredibly vulnerable. They're grieving. Their sense of normal is shattered. They're at high risk for ASD, PTSD. Nurses need to convey safety and listen non-judgmentally. And if there are concerns about PTSD, there are tools to help assess that.
Like the IESR scale mentioned in the text.
Exactly. The impact of event scale revised. It helps gauge the level of distress.
And what's the score that tells a nurse, okay, this person needs more help?
The text highlights a score of 33 or higher. If a survivor scores that high, it suggests probable PTSD, and that requires an immediate referral. Document it and get them connected with mental health support, a counselor, a psychiatrist.
Okay, so let's try and bring this all together. We've covered a lot in this deep dive. We really focused on how resources define the difference between a multi-casualty event and a full-blown disaster. We looked at the HICS structure that brings order to chaos, the really difficult ethical basis of the disaster triage tags, red, yellow, green, and black. And we emphasized the crucial role of nurses, not just clinically, but in being flexible, prepared personally with go bags, and supporting recovery.
And thinking about that recovery phase, it really highlights the need for coordination, doesn't it? Specialized teams like DMATs for medical surge, DMORTs for the difficult task of managing mass fatalities, even NVRTs for animal care become critical. Considering how frequent and large-scale disasters seem to be getting globally, maybe the big provocative thought to leave listeners with is this. How well can our national mutual aid systems truly handle multiple simultaneous large events? Are we there yet? And what needs to happen next, perhaps with things like nursing licensure across state lines, to make sure help can get where it's needed instantly without bureaucratic hurdles when the next big one hits?
That question of truly seamless national level response and readiness, that's definitely something to think about long after this deep dive ends. Thank you for joining us today for this critical look at disaster preparedness. From the whole Last Minute Lecture team, we appreciate you tuning in.